I'll put full screen.
You are live. Hi, welcome to our new series of Food, Medicine and Lives today. And we have none other than Dr. Vivek Kadamni with us, who is pioneer in bioidentical therapy in Indian setup. So welcome, Dr. Vivek.
Thank you, Dr. Preeti. It's a great honor and pleasure for me to be here.
Thank you. So today the topic which we are going to talk about is T3. I think some of us know and some of us don't that T3 is the active form of thyroid. And in the last few years, lot of research has been done on T3. And that's an area Dr. Vivek has really worked with his patients and learned the newer depths of using T3 for a better life. Dr. Vivek, I welcome you and please share your thoughts on what do you think about T3?
Yes, so thank you very much, Dr. Preeti. So let's get straight to the point. Let's now put the spotlight on T3. As you had very rightly introduced the topic, most people, when they use the word thyroid or hypothyroidism, they are not aware of the fact that there are two types, at least two major types of thyroids. One is called the T4 and the T3. And what is very commonly used for treatment of hypothyroidism is a we must have heard of drugs called thyroxine, Eltroxin. These are drugs that contain essentially T4. And it's very important to understand that while T4 is a very effective drug, it works very well, it really doesn't solve all the problems that are associated with hypothyroidism, particularly because it's not the active form. The body has to convert that into T3. And the T3 is what really gives all the benefits for anybody that is trying to use that for treatment of hypothyroidism. So just so that you understand, in very simplistic terms, the thyroid gland, which is located in the neck, produces two types of thyroids. One is called as a T4. 80% of it is T4 that it produces, and about 20% of T3, which is active form and 10 times more potent. You can also say that the T4 is a precursor with low potency to the T3. And these drugs like thyroxine, Eltroxin, what we normally take for the hypothyroidism or is prescribed, is nothing but the T4. Now, although this may look a little bit complicated, it's quite simple to understand that here you have the thyroid gland. 80% of the thyroid hormone that is being produced is the T4, but 20% of T3 is being produced. And this T4 gets converted into the T3 in the peripheral tissue. It could be in the liver, as you could say in the brain, the kidneys, the muscles, etc. And this T3 is the one that gives the real action of the thyroids. And we will come to what the T3 does. There are a couple of important enzymes here, which is called the deiodinase, and the deiodinase 1, deiodinase 2, and the deiodinase 3. Now, these are the enzymes that actually remove one molecule of the iodine, and that converts the T4 into T3. And there's also a very interesting subset of this hormone called the reverse T3 or RT3. Until now, not much of importance was given to RT3, but remember that this also is a T3, but with the molecules of the iodine slightly in a different position, almost like a mirror image. And this actually is inactive form of T3. And therefore, very often, even if you have enough T3, but if one has more of RT3, you don't get the clinical effects. Now, having said that, let's just simplify. I'll just try and understand certain things that can increase this T4 or increase the T3 production, and certain factors. Yeah, go ahead.
Dr. Vivek, I have a question. Yes,
sure.
This slide is like, it has deeper and deeper and deeper layers into it. So there are two questions which are coming to my mind, and I'm sure to the viewer's mind is,
yes,
you said T4 has to be converted to T3.
Yes.
Right. So what are the 2-3 things which you have found in your patients which actually decrease or inhibit this conversion?
All right. So in general, I would say that almost every patient that comes to me are the ones that are not converting T4 to T3, because if they were, they would probably not come to me, or they would not find me, because the T4 was serving the purpose. But
Right.
the commonest thing that I have seen, because I suppose that the kind of patients that come to me are those with PCOS, fibroids, menopause, etc. Estrogen dominance seems to be, as you can see over here, estrogen dominance seems to be very, very common among those who come and seek my help. The other factor that I have seen is in Hashimoto's. I've seen almost 80% or more of my patients, they have antibody, anti-TPO positive, and they have what's known as autoimmune thyroiditis and Hashimoto's. So that is the second factor that I've seen very common, and therefore I can safely say that in these patients, the reverse T3 is much higher. As it is, the T4 connected to T3 itself is very low, but in addition, they have a high rate of reverse T3. And stress being a very, very common factor, many of them have this raised cortisol levels. That's one. Okay, so these are the common what I come across, but your question is very, very relevant. There are so many factors which I shall now talk about, and you will realize why it's so common to find somebody who's taking L-Droxin, Thyronome for long periods of time, but really not getting the complete benefit from that.
Right.
So I hope that does that answer your question?
Yes, but something is coming in my mind, Dr. Vivek. So,
Sure,
Dr. Vivek, I have started working a lot on cortisol issues.
All right, very good.
I've come from a corporate background, and I have, lived that life of working 16, 17 hours a day, traveling from one place to another, always with your reports and your team and stress. So,
yeah, high strung.
Yeah. So what I realized was that high cortisol has now given way to having low cortisol. So currently I'm running a group of 12 people in it, where we are helping people increase their cortisol levels, because over the years, in the last 8 to 10 years, their cortisol first went higher, and now it has come so deep down that their body do not have the necessary fuel which they need.
I get it. Yes.
So I think the way, the focus on T3 has increased, and the requirement for T3 has increased. Like you said, in estrogen dominance, in, vitamin D deficiencies, in ferritin deficiency. Similarly, I think cortisol also now has started becoming low in a lot more cases than what, at least I had seen in my practice in the last 3 years.
Yeah. So let me put that in perspective. No, let me put that in perspective. And you're absolutely right. And since the topic of cortisol came, and one general rule I like everybody to understand, that you can't take one hormone in isolation. If you're talking about thyroids or T3, you cannot ignore cortisol, insulin, and other hormones. So let's just say cortisol. Initially, stress. When you're high strung, your cortisol levels are high because the body is trying to overcome the stress. So when the cortisol levels are high, just imagine what's happening behind the scenes. More and more of reverse T3 is being produced. Therefore, less and less of the main T3. And again, you're getting the same symptoms as you would get of a hypothyroidism getting worse. That means low energy levels, weight gain, all those kind of things. Now, after some time, there is something called as adrenal fatigue. So the adrenal fatigue and the cortisol levels actually start falling down. Now, when the cortisol levels start falling down, then at that point of time, theoretically, even if you were to assume that the T3 will rise, just for as an assumption, the fatigue or the low energy levels or that symptom does not go away. Only the reason for the symptom shifts from not enough T3 to not enough cortisol. So you need cortisol also to be balanced. And you're absolutely right. We are seeing now more and more cases of low cortisol. So in those cases, it's very important to make sure that you have the entire picture clear. If you only measure the thyroids, you might miss, like you talk about a large number of cases that have low cortisol. And therefore, you might be treating with a wrong, with the wrong supplementation. You may be focusing so much of the thyroids that you will be ignoring others, just as we talk about vitamin D and other things. So you're absolutely right. If you are looking at a clinical scenario, you have to make sure that you have all these put together. And high cortisol as well as low cortisol both have the same effect on the thyroids and clinically, but through different mechanisms.
Through a different mechanism. Thank you, Dr. Vivek, for bringing this up so clearly, because somehow I think a lot of doctors also are, missing this little connection there.
That's true. And also remember, when the cortisol starts falling down, that could be adrenal fatigue. But the cortisol actually is there to protect your body also. So it is trying to control inflammation. So if the cortisol starts falling down, the inflammation starts going up, and the inflammation again can affect the thyroids, the insulin, and the other hormones. So again, there's an indirect effect. So therefore, when we look at hormone balancing, the science is very well known, but there is an art of balancing, both the science and the art that comes through, of course, training, taking the right courses, understanding, doing a research, and also through practice. So there's no doubt that about these things. Now, I wanted to highlight one factor that you can see there, the T4 medication. Now, this is very interesting that you're taking T4, it starts giving you effect, the L-Troxin, and then after some time, very classically, I've heard my patients say that I've increased the dose from 50 to 100 micrograms and more, but now actually I'm getting worse. So as you can see, this is a very fine balance that if you give more T4, and the same will apply to iodine also. Iodine here, to some extent, it promotes T3, but T4, after some time, it increases the RT3. So clinically, you'll have that issue. And when I go to the next slide, here, you can see here that if you, all the factors, this may look like a slide with a lot of noise, but if you understand, don't focus on those text that is all around, I'll come to that. If you understand that there is some phenomenon that as the T4 increases, it actually gets bound by a protein called ubiquitin protein, and this binds to T4, doesn't allow it to go to T3. It's a sort of protective mechanism, but that actually makes it worse from the clinical point of view, that your T4 after a certain level actually stops converting to T3, even in those who normally would have converted. Similarly, I've highlighted excess iodine. So person is taking iodine, so iodine is more to do with those who have goiter and iodine deficiency. So if you overtreat the iodine, again, you have a problem that excess iodine also prevents this conversion. And then now look at all the factors: age, stress, sleep, lack of exercise, obesity, alcohol, smoking. Now, anybody who's watching this, if you have any 2 or 3 of these, I'm sure that you look at it and say, yes, I think I have 1 or 2 of these. And therefore, I would say that not just 50% of the population, now more than, I would say 80% of the population will have some of these factors. Therefore, in the clinical settings, although they say that that T4 should be the first line and then only use T3 in those cases where the T4 does not work, in the clinical setting, it almost comes to practically at least more than 50%, if not more. I would say 80% will come into this category. And lastly, there is an enzyme defect which is seen in 12 to 36% of cases. And this D2 enzyme, this D2, so you can say ki 25%, 25%, so they're already not able to do it. So that is high. So
really significant.
Yeah, so that means if you're looking at just the statistics alone, and unfortunately, most of our statistics we get from American studies and studies done, European American studies, but we have to apply them to India also. India-specific studies will probably also show a similar thing, but assume a large section of the population have this enzyme defect. So enzyme defect, environmental factors. So when you look at all this put together, I am not surprised that a large section of this of the population who are taking T4 or taking the normal treatment for the hypothyroidism, they take it, but they have to work very hard. They have to do a lot of exercise, really control their diet, and then finally they say that, look, I'm doing everything, I'm killing myself, but I am not losing weight. My moods are still low, etc. So this is where which seems to be a very common scenario today.
Dr. Vivek, I can really relate to what you just said, because I practice majorly in obesity.
Oh, I see. And you told me that very much.
Yeah, and as I told you that I also work on cortisol and estrogen dominance stuff more. I've observed 2 things recently. One, I have observed that hypothyroidism is increasing because of multiple reasons. Some of them could be, some people have just stopped taking iodized salt at all. They don't even take a pinch of it. And on the contrary, there are some people who eat so much pesticides. They're so stressed. They're obese that all that is not working. And I think one even bigger factor which comes to the foreplay when I talk to them is that other than the fact that they don't have to eat, cabbage or cauliflower or bok choy or broccoli, they don't know anything much about what can they do to increase T4 to T3 conversion. Like, we're not talking much about the supplements like selenium and all, which are required, like good levels of ferritin, which is required for proper functioning of thyroid. And so
Correct.
much more, which your slide is saying, because low progesterone, low testosterone, and low HGH is,
Yes.
I think majority of people are going through this.
Yeah. Anybody over the age of 40, 45 will definitely have these.
And even younger, I see them in practice
Oh, yes.
every day. So
Yeah.
I think this slide which you've shown is
Mhm.
so complete in itself. Thank you for putting that up here, because this gives a whole perspective to the thyroid at a very different level. Thank
Absolutely.
you. Yeah,
In
I
fact,
think very,
my reason for actually putting this is that there are so many factors which you can't help. For example, we take processed food. The food has pesticides. Much as I would like to have my home cooked, homegrown food and organic,
right,
etc. In practical life, is so difficult, and all these seem to affect. The point I'm trying to bring out from here is that at least let us be aware of it. The first step towards taking any action is to at least be aware that this problem, as it's been put, was that, okay, the way it was put to me, if you had asked me 10, 15 years ago, was that, come on, most cases with thyroid, with T4, L-troxin, they're good enough. You don't have to worry about it. Very few, small percentage of cases may need the T3. But I have seen
right,
it's actually the other way around, that yes, it depends on what your goal is. If you want to say, chalta hai, just good enough, yes, anything will do. But
exactly.
if you're looking at optimizing your health and a good lifestyle and quality of life, then you should try and understand. And the best example I give is that somebody has a surgery, post thyroidectomy. Now, post thyroidectomy, if you do not give them the T3, they have a lot of because 20% to immediately chala gaya. The 20% of T3 which was being produced by the thyroid, that is gone. Upar se you have all the other factors that come in, because a large number of post thyroidectomy is also because of the thyroid cancers, and therefore there we find how beautifully the T3 work. So my point is, why wait for an extreme condition where you have to remove the thyroid surgery and then start thinking of T3? You can think of T3, and let me give you some guidelines. Yeah, you were asking questions. Sorry. Yeah, I heard you
Yes,
say something.
Dr. Vivek, no, something is coming to my mind. Once I was reading a book. So my younger son is doing law, and we
I
keep
see.
having
Okay.
debates between medicine and law. You know how
Right.
lawyers are. So
Sure.
he was telling me, Mom, ignorance is not enough to get you out of the court if
Yeah.
you have
That
been
was. Yeah.
screwed up, right? So
As
when
well
you
said.
were saying this, I think ignorance about not knowing the benefits of T3 and how it can help our patients live a fuller, healthier, energetic life
Right.
doesn't, put us on the right
Absolve
side.
you.
I think
Yeah.
all of
So
us should know about this because it creates a
yeah.
significant change in the lives of the patient.
I understand. So in a nutshell, I totally agree with. Very rarely I agree with lawyers, but in this case, I have to agree with a lawyer's son. That perhaps ignorance can also be a crime. So you cannot get away. You cannot absolve
Exactly.
yourself. Let me pull my
Exactly.
punches back. Let me pull my punches back. You can't absolve yourself from the ignorance. After having the fact, you can decide whether you believe in it, you have conviction, or you want to use that information or not. But not having the
Exactly.
information, at least today, in today's world, that's not acceptable. So how do we know? Look at the one here on the right hand bottom corner, that many people have normal TSH, and I'm quoting, not quote unquote normal, because there's a big range, 0.4 to 5.5 to 5.5, etc. The T4 looks normal in the lab, and they say T3 also looking low normal, but the symptoms are there. All the symptoms of hypothyroidism is there. So every time they would go to a doctor and look at the levels, they say my levels are okay, but why am I not feeling good? Then usually they get this answer that no, you're not, you're unhealthy, you're a glut, you're cheating on your diet, you're not doing enough exercise, you are depressed because psychologically you're depressed, you have to work on that. So they also get a bit frustrated, and therefore this is a very typical sign that everything looking good on your labs, but you're not just feeling better. So that is one of the first, they should raise a red flag for anyone. Now,
So
when you
what
look
are
at the
the
symptoms
general
of
symptoms?
hyperthyroidism,
Yeah. Sorry. Yes. Okay.
yeah, so this is, yeah, good. You asked me the question. I think I anticipated it. So there we go. So
Right.
I knew that you would be coming to that because from the symptoms. Now the question over here is, this is the difficult part, because there are so many symptoms. Okay, that you can practically relate any symptom to thyroids. Okay, this is the reality. But when I say thyroids, let me correct myself. Let me be more accurate. You can attribute any symptom to a imbalance in the hormones. Now, thyroid, if you take among the very, yeah, go ahead. You were saying something.
No, I said this is such a beautiful way of putting it, because now role of hormones is being talked about more and more, because I think somehow
Yes.
they are coming on the forefront.
Right. And gradually, of course, everything seems to be related, finally coming down to the hormones and the balance of hormones. And it's sometimes the answers are very simple, but it's not easy. I always say that it's simple to understand. Yes, imbalance of hormones, but to balance them is not easy. It takes a lot, depending on, it takes a lot of effort. It takes a lot of knowledge. It takes a lot of expertise. But what the point I'm trying to also say is, why does let's talk about thyroid so much? So look at it. If the hormone was a corporate, you've been from the corporate world, you said, so Dr. Preeti.
Right.
So if the entire hormone system, if you corporatize it, the thyroid is the CEO. The chief executive officer is the thyroid. Okay. So what happens is, that's exactly why that a lot depends on the thyroids, and a lot of the symptoms are affected by the thyroids. Okay. The other, COO, if you were to call, would be insulin. So the other hormones would actually also, they together. But the CEO of the hormonal hormones incorporated of the human body would be the thyroids. And therefore, whenever we talk about hormone imbalance, let's say that a large part of it depends on the thyroid. Large part. I mean, it's not necessarily all. So if you look at brain fog, mood swings, frequent headaches, infections. So if you just look at this picture, and there are many more. So it doesn't really help. But the person who's having the problem will know which is the main problem, which is the problem that I'm facing. And I can tell you, for some people, it is the mood. For some people, it is the hair fall. The skin and hair fall is the worst, kind of thing. For others, it is the weight issue. So,
cold intolerance, Dr. Vivek.
Yes, cold intolerance. And then they're not often taken very seriously, because
exactly.
A person who's suffering from cold intolerance, while everybody else is laughing at the person, saying, look, it's not that cold, and you're in the sweater and you're putting this rajai and all that, something must be wrong with you. So, it actually doesn't help. And if you are really sensitive to what's happening in that person, it could well be that the thyroids are not well balanced in that person. So, that kind of the impact of hypothyroidism is so much on the psyche and the personality also of the individual, that I feel it is just more than just physical health. It really gets into a person's not just the psychological health, but the social health also, because it really makes a person very embarrassed, almost to the extent that feels gets an inferiority complex also, because when they have these symptoms and nobody seems to understand, you can imagine where they are. And that's where I see a lot of gratification when I help my patients get into a better social environment.
Definitely. So, Dr. Vivek, I see that, in my practice, I've seen that use of T3, I find a lot of benefit being given to patients when they come for weight loss, for depression, and for energy loss. So what is your thought?
Yeah, in fact, I can tell you, I must compliment. I've seen your various programs and even books on how to cook healthy. You do so much on cooking and healthy, which I don't do, but I would love you to take care of some of my patients when it comes to their diet and cooking, because it doesn't just by the T3. The T3 is not a magic wand. It has a lot of power. But you also need to have someone that will guide you correctly. So you have a good combination, because I can see that you also use a T3 in your practice, but you rely a lot on on diet, on actually teaching people how to cook. And fundamentally, I think in the long term, that's what gives the foundation. What we give the thyroids, or if you need insulins or the estrogen or the progesterone over and above that, it is cannot be sustained unless you have a very strong foundation in the diet and lifestyles, which is what you do very much. And
that's why, Dr. Vivek. Yes, I see people transforming on it. Yes,
and as you can see that, in fact, let me make a bold statement here. It appears that thyroid or hypothyroidism or thyroid is the most misunderstood topic in the medical world. Okay. It is also the most undertreated condition that I can think of, and this testimony to that is, if you just go online and you see the number of books that are being written on this, why do I still have thyroid symptoms? Stop the thyroid madness, a healthy thyroid healing. So you see the number of books that have been written on the thyroid. It shows that the majority of the population, they are looking for answers, they're looking for solutions, and what we are providing in the medical world, unfortunately, is not enough. and it often gets hidden because it's under that water of the iceberg. We see the tip of the iceberg. We see the diseases. We see diabetes. We see hypertension. We see fibroids. We see all the tumors, cancers. But its relationship to thyroid and hormones is often it comes too late. And hence, if you look at the number of books itself that have been written on it, should actually is testimony to the fact that in general people are looking for answers. It's not thyroid has the present management of thyroid that we are offering collectively. I'm talking about the medical profession, definitely is not satisfied. It's not up to the mark as far as the general public or the population is concerned. So we can't ignore that.
I definitely agree with you. No, and I definitely agree with you, Dr. Vivek. So I'll tell you something. I was a medical advisor with Cipla about 20 years back, right? And I was in the respiratory division.
Okay.
Right? So we were discussing internally and said, why do cardiac drugs sell so much, but asthma drugs don't? Jabki we saw data saying that asthma kills as many people as heart disease does. Right? And then this thing came up that maybe, cardiac disease is more talked about. There are surgeries and other stuff which can be done there. So more people are talking about it. And when you said thyroid today, I think I could relate it to asthma. People don't know. People think these symptoms are just coming because of nothing. Maybe it's just a mental thing, or maybe, there's no problem, because the levels are also so wide. And the consequences of unmanaged thyroid are also not talked too much.
Yeah, I do agree. And to draw a good analogy, it's always the celebrity, the star of the show, the hero out there who gets all the attention. So cardiac surgeries and the cardiac disease, which kills suddenly with pain in chest and all those kind of things will get more attention. And very often the other workers or the backstage workers, they don't get the credit. Yeah, that's
and thyroid kills you every day, because the type of symptoms you have with thyroid is actually killing you every day. So, Dr. Vivek,
don't forget that. Go ahead.
Your thoughts on weight loss.
All right. So I'm coming to this now. The three things which you particularly specifically mentioned. When I look at the, once you get optimal levels of the free T3 let me explain to you what free T3 is. So now most people, they check what is known as a TSH, and that is known all over that if your TSH is high, your thyroids are bad. If your TSH is normal or low, that's good response to treatment. Unfortunately, TSH is a very poor independent indicator of thyroid status. Whenever you do the TSH, always do the free T3 and the free T4, especially the free T3. So once you get optimal free T3 level, so when I talk about a treatment of the thyroid, I'm talking about reaching a level of free T3 from the labs, but not necessary. Sometimes you have to override the labs and go by the clinical symptoms and even go higher. So don't always think that it's a free T3 level that is going to guide, but it's a starting point as far as I'm concerned. Now, among these various benefits that I have listed out, and this would take us all day if you were to talk all of them, you have taken three important ones: energy, weight loss, and the better moods. Okay. So let's just take these three, and I will summarize very quickly for somebody to understand: energy, weight loss, better moods. So let's take energy. Now, the fundamental the role of T3 or thyroid is to increase the basal metabolic, increase metabolism right at the level of the mitochondria, intracellular, all over every cell in the body. And that is fundamental, and that's why it becomes so important that you find the symptoms right from the brain, head to the toe. All the symptoms will occur when you don't have enough thyroid. Now, the basal metabolic rate contributes as much as 70% of your energy. Physical activities another 20%, and the calorie thermogenesis another 10%. So basal metabolic rate is one of the things you can even measure, that when you actually have hypothyroidism or not enough T3, the BMR or basal metabolic rate is low. So it brings that up. So once that brings up all the energy, every cell, and remember, when we talk about energy, it is not this energy that makes you jump and run, etc. Energy that also improves the efficiency of every cell, the liver, the kidneys, functioning of the brain. So the energy that is generated from there comes in all the tissues. So you can understand that every cell in the body where the metabolism is going up. But also remember, thyroid cannot do this alone. It works along with insulin, and it's a two-way. If you see the arrow over there, it is going both ways. Insulin, if insulin is deficient, the thyroids have a problem. Thyroid is deficient, then insulin. So both these, as I said, the CEO and the CEO of Hormone Incorporated, if they don't work together, it's a mess. But don't forget testosterone, progesterone, and others also, and the human growth hormone. They also will contribute to this. But This is the one who's running the show. So
yeah.
it's
So
easy
Dr.
to
Vivek,
understand.
here we have a question, very beautifully put, which says, any relationship of hirsutism to hypothyroidism?
All right. So whenever somebody asks me this, it's like this. It's always the cause effect is very important to understand. But sometimes if you just say they coexist is good enough. So let me tell you, let's say that a person has got low thyroid, not enough thyroid, and hence that has given rise to insulin resistance or worsening of insulin sensitivity, and therefore leads to PCOS, etc. And therefore let's say in a young girl that the ovulation is affected, and therefore there is a little bit of excess of testosterone, DHT being more. So now you see the indirect relationship. So when the thyroid is being affected, you're affecting one, it sort of cascades, and you will definitely find in many of these cases that the free testosterone level in a woman is high, and therefore, or even in menopause, you could say the similar situation arises, and therefore you will find that they have hirsutism. But that doesn't mean that every case of hypothyroidism or low T3 will necessarily go in that direction, but in a large number of cases it will. And because it affects the estrogen, progesterone, testosterone, if you were to find that, yes, therefore when you handle it, it's not only a question of thyroid, you must address. So there is a indirect, or in some cases direct, relationship between hirsutism and hypothyroidism. Therefore you will find yes, and the PCOS also.
Also, Dr. Vivek, yes, I was about to say that I work very closely with PCOS girls, and I've seen that most of the PCOS girls land up being hypothyroid, and then having hirsutism, and all this picture come together in these patients comes up very commonly, very commonly.
Yeah. And then, as you've seen in the beginning, as you explained, the cause for the hypothyroidism may be as simple as a vitamin D deficiency. It could be as much as not having enough B group vitamin. So it's like fundamentally they all have to work together. Once you understand in functional medicine that you cannot approach hormones unless you approach the nutrition and diet first. It's not the other way around. You can't first do the treatment with the thyroids and then do something about nutrition and diet. Nutrition, diet, lifestyle, exercise should always be the first level. That's a foundation. Then a lot of the other factors come. So we've seen that in PCOS. You would have seen that most of the time it is sort of related to that. So now that we have a lot of energy levels, obviously this energy has to go somewhere. So if the calories are being burnt more, then it will lead to a healthy weight loss. But now let me tell you the thing about the weight loss, and this is a very, very tricky condition. Now let us say that along with insulin, testosterone, growth hormone, and they all work together, you have better insulin sensitivity, because insulin sensitivity also, because if you have insulin resistance, you get deposition of fat around the abdomen, weight gain, etc. There is increased energy levels will come because of the improvement of T3. Then the stamina goes up, you can do more exercise, and there is a motivation. Motivation is important because even the mind starts becoming very positive, and therefore good sleep, nutrition, fitness, energy, all that put together will lead to the healthy weight loss. So if somebody says that, yeah, take the thyroids and you will get weight loss, I think you're raising false hopes. There's got a lot of expectations, and I will have a lot of disappointed. So very important, and I'm saying this, I cannot stress this more. Do not abuse thyroid for weight loss or slimming. Healthy weight loss occurs gradually, and it's a result. I would say it's a very pleasant side effect of thyroid optimization along with diet and exercise. So if you have that perspective clear, yeah, you were saying something? Yes?
Yes, I was saying that basically I tell my patients that, weight is just as indication that the hormones are in imbalance.
Right.
You just put your hormones in balance, weight will just flow out like water from your body, and you will, be your optimal weight.
That's true. So therefore, I'll bring out one very important point. We have a system that any time a patient comes, as you know, I'm on 100% on a telehealth platform. The first part is that counseling, and during the counseling, if we realize that this person is here for weight loss, this person is not interested in anything else, they're just talking about weight and weight and weight, we actually discourage the patient and say, perhaps we are not for you, because you're going to be disappointed. Because if you gauge the results by weight loss, and you're going to be a couch potato, and you're not going to do anything, and thinking that taking these thyroid pills is going to make you lose weight, well, both of us are going to be disappointed. That's not going to happen. That's not going to happen. So while I know that yes, it can help a lot, and there are many those who will even go to the extent of abusing this. That's there. This is the reality. But the statistics will never be known. While that is there, I believe that if a person understands that by optimizing my thyroids, I will have better energy, better stamina, better motivation, and whatever exercise I do, I say you will get more, bang for the buck. For the same amount of exercise or same amount of gym that you do, you will feel that you will get a better weight loss. But remember, if you put on more muscle, and it's not necessary that weight per se will come down, but you'll be slim. Yeah, you'll be trim. You can really go trim, and therefore,
and you will be fitter.
You'll be fitter. So fitness doesn't always necessarily mean that it's a weight loss. In fact, there'll be a balance. There'll be some weight loss because of loss of the fat, loss of even the excess weight that you have. But if you actually put on more muscle and you take enough proteins, it would sort of even balance. So it's not always all about the weight. Don't go so much focus on the weight that you lose sight of all the other benefits that you can get. So this is always my biggest issue, and I make sure that everybody understands this. So I don't even talk about weight loss till about 6 months. Since there, 3 to 6 months, we only talk about making sure vitamin D, B12, and your thyroids and the other hormones are all well optimized. And we make sure that you're on a good program. And then after that, you're on cruise control. And very effortlessly, I will put it this way, very effortlessly, you'll not put on weight. And you reach that stage. All right.
Exactly.
So that is why that weight issue is a bit tricky. So but, if you're very clear about it.
I have a question. If patient has insulin resistance and hypothyroidism,
yes,
should they be treated together or start with hypothyroidism?
Yeah. So if you have a person of insulin resistance, let's say, and clear-cut defined, I would first say, okay, vitamin D, B12, lifestyle, etc. has been done. Then I would look at thyroids as the option, because what do I have options? I have options between thyroids and using drugs like metformin, using injections like Victoza. There are so many other options I can use for treating the insulin sensitivity or insulin resistance I can do. So how do I go about doing this? I often see that are the other symptoms very prominent? If it is only a question of insulin and it's not very bad, fasting insulin levels are like 15, 16, and it should be less than 10. But let's say it's not very high, 12, 11, 12. And I said, okay, let's just give the thyroid a chance, because the thyroids are, or if the thyroids are really bad, if there's autoimmune thyroiditis, so then in favor of thyroid. So whenever you take a decision clinically, it is not based on one factor alone. So yes, insulin resistance, I would rather treat first with thyroids, then with metformin. Because once I get into the medical part, they're very good medicines, metformin, Victoza, a lot of medicines that are often used for insulin, they work very well. But just as a protocol, my first thing is that first hormones, and then the medicines that you can use, or simultaneously also, depends on what extent.
Also, Dr. Vivek, if insulin resistance is not very steep.
It's not very, exactly.
A slight change in diet and exercise protocol.
Yes.
Can set it right, and you work with thyroid, so the patient starts, coming back on track very, very nicely without.
I'll give a very good example. Suddenly, you have a person has gluten, sensitivity or something else. So if you've missed that, then you're wasting your time with all this. But all the same, do not overdo the gluten. Now everybody seems to be going for gluten-free without even thinking. Everybody seems to be rushing. You kick the ball in the air, and everybody rushes towards it. So the question over here is that if you are looking at some factor, it should, when you look at it, yes, I'm seeing the inflammatory markers are high, antibodies are going high. Let me see what's happening over there, and let me try to get those into all balance. So it's exactly like this. Do not try and only fix one problem. Try and get all the problems together, and this is how you have to guide the patient, and they will manage. And secondly, you have somebody who says, I can't tolerate this medicine, I get gastritis, I can't tolerate metformin. Yes, okay, then we have to sort of shift the balance. So individually, you have to customize it to the individual. Even the T3 dose, unlike the T4, has to be customized. You need the right balance, 1:4 balance. There's an entire science and art in how to customize this. And luckily, we have a compounding pharmacy. We compound these medicines that can make these combinations. You yourself have been prescribing so many of these compounded various combinations. So that is how you will discover what works for that one individual. What works for one individual will not always work for the next. But if you look at I'm using the word holistic, not as Ayurveda or homeopathy and that sort of a terminology of holistic. I'm using it holistic is you approach the condition in a holistic manner. Don't only focus on thyroid or insulin or testosterone. Just make sure that in a holistic way, diet, exercise, other hormones, address that, and also find out what is it that the patient wants. What is it that drives them? You may want perfect health in them, but for that person, it may be, I want peace of mind, I want good sleep, and I want enough energy. So sometimes it's more important what they want. also.
A very important point, Dr. Vivek, you've brought up, because you know what? I think I was in one of the panel discussions 2-3 years back at ASSOCHAM, right?
I see.
And this came up saying, what will you do if the patient comes with these reports?
Mm-hmm.
The best answer which was given there was, it doesn't matter. Reports are just a tool.
Right.
Patient has to come and tell me what is his problem. Why is it that he is walked from his house to my place? And that is the thing where I will start to work on.
Yeah, and when we also work on telemedicine, therefore I insist on a video conferencing. I don't like pure audio because by looking at the body language, looking at the expression, you can see the hair, the skin, so many things that come on. So when we do a teleconsult also, while many patients feel embarrassed to come on the video, I often insist and I tell them it's for you. Imagine if you had come to me face to face, I would have, you would have walked in. But right now this is equally important. The body language, the tone in which they say, you can sense that. So I'll go to the next part, which this is just for information. People often ask me, okay, they just say, where are the studies? Show me the studies. There are hundreds and thousands of studies. I'll just pick a few of them. One says that reduced body weight, if the substitution of T3 for T4 at equivalent doses resulted relative to the pituitary, reduced the body weight, resulted in greater thyroid hormone action and lipid metabolism. In anybody who has a cholesterol issue, my answer is not to use statins. You balance everything, balance the thyroids, and beautifully the lipid will also balance by themselves. It's all there. As you see, it's there in the journals. Tera hi tota kehta hai sort of thing. I would say there in the journals. Right. So again, they have used it for female sexual functioning is better, or reproductive functioning is better. Then improve mood and psychological function. So there are so many articles out there that it is known that T3, and now comes the most important part here, that I believe that the most useful aspect of T3 will come for treating depression or mood disorders. And this I am seeing more and more, because otherwise we have to depend on therapy, we have to depend on medicines which have so many side effects and actually just makes your emotional dull. It dulls your emotion. That's not the idea. We don't want people who are depressed to just have no feelings. You need to feel down when it's a sad event. You need to feel up, but it's only a question of relative degree. So when I look at anybody when we talk about depression, it is criminal if you do not investigate for simple things like vitamin D deficiency, a low testosterone, low progesterone, and a low thyroid. So it is so common that in menopause, when they say is depressed, they often say, no, she's depressed because, the hair is becoming thin, the skin is putting on weight, etc. That's the secondary cause. The primary cause is the lack of the hormone itself is causing the depression. Now, this is again been proved that T3 is actually been used in therapy. And I'm again stressing this fact. In other forms, in other case scenarios, you can use combination of T4 or T4, T3, whatever. But in psychiatry, in fact, psychiatry journals, psychiatrists were the first one to use T3 as a therapy for depression. And when they found that we use T3 along with the SSRIs, that is the selective serotonin receptor inhibitors, they found that it augments. Now, again, am I saying this out of my head? No. All these are published in the journals right from 2009, 1999, if I remember, that it says that it is of interest that number of psychometric scores improved significantly with just 12.5 micrograms of T3. That's one. Wow. There is an augmentation. This is very interesting. Supra-physiological doses of T3. That means psychiatrists, they have this privilege that if I have a psychiatrist supervising my patient, I can go to even supra-physiological doses, even what is considered as a hyper or a dangerous dose. It's not dangerous. It's one of the safest, because you are allowed to go. If you look at the cost, if you look at the benefit versus the downside of using high doses, it is much better than the antidepressive medicines that we use. So psychiatrists are actually allowed to use supraphysiological. Now that should tell us something.
Yeah. So Dr. Vivek, when you say supraphysiological doses, what are the doses you've seen people using or you have used in your practice, which is the highest?
Yeah. So I would say that most of the time people use about, there are a lot of people I see, they're so scared, they use 5 micrograms and 10 micrograms. I believe that nothing happens with 5 or 10 micrograms. Although I have seen a few patients with as much as 2.5 micrograms, they even get palpitations or they get some symptoms. So I'm not going to individuals. But if you were looking at a good dose of average dose of thyroids, it's about 20, 30. And remember, T3 is often should be given twice a day, unlike the T4, because it's got a short half-life. if you, whatever T3 you give in the morning, by late afternoon, that has already been metabolized because it's got a short half-life. So let's say in a day, the person gets about anywhere between 20 to 50 micrograms. Now, when we go for treatment of depression, you could go as high as 50, 100, and for a short period of time, even I've seen cases that take 50 twice or even thrice a day. So the question over here is that whenever you go for the supraphysiological doses, I'm not saying that you should just give the dose and just leave it at that. You have to closely monitor also. So therefore, whenever you go for the higher doses, the rule is they should be more frequently monitored also, not just by the blood levels, but by clinically how they're doing, and look for the pulse, simple things like the pulse rate. Today you have all these devices, that measures the spirometer, and also you one very easy thing is that you just ask the person to do that. Or if I sometimes believe that the person is not honest about the pulse rate, I say, come on video, put the finger, show me, and I can actually visualize. So I can actually make sure that I'm monitoring the pulse rate. So pulse rate is a fairly accurate. You can't have a person that is getting excess of T3 and the pulse rate is normal. But you could have some people with high pulse rate, but they're still in the T3. So that is how you should be able to monitor. So my point is this: I've heard of doses that even go 50, 100, or 150 also. I don't think I have exceeded more than 100 per day. But as I said, that if you are able to supervise and you're confident that this person is not going to abuse it, you can imagine a person who's depressed may actually land up taking more of these. But the good thing is that no matter how much they take it, if they people have taken doses you won't believe, 1,000 times the dose, where there was a mistake between milligrams and micrograms. They have taken 1,000 times the dose. They have become very sick, but they have not died. So what really is what I'm trying to say is that it is probably one of the
very nice way of putting it, that it's not as lethal as one would think.
Yeah,
and
in fact,
it comes with lots of benefits.
Yes, often said that if I had to say this because people may be sensitive about it, but I must say this and I hope people take in the right sense, that it is said that if you want to commit suicide, don't go for the thyroid. It's the worst drug to try and attempt. You may swallow the whole bottle, you'll be sick, but it's not going to kill you. Except, of course, there are exceptions. Somebody has a heart disease, existing pre-existing condition. So let me not trivialize that part. But yes, so this is what has come out. That psychiatrists have been using supraphysiological doses, and therefore all the benefits of T3, all what advancement we have T3, the credit goes to psychiatrists. I'm sorry to say, not to endocrinologists. And it's not their fault. It's only that the psychiatrists have this privilege because they can judge the case, which endocrinologists cannot. So remember, a lot of research, a lot of data has come from the psychiatrists. Now look at this one: triiodothyronine with selective SSRI. That's again published over there. Then they say that there is a enhancement of antidepressant effect of sertraline, etc. with this. Now, partial substitution of T3 may improve moods and neuropsychological function. So there are so many such studies over there that at least if you believe that today, and a lot of us believe that depression is becoming a major issue. It's much more than the statistics tell us. So if somebody is not using the thyroids and vitamin D and other things and only using medicine for depression, I think that is a grave that's a disservice that you're doing to the society and patients. I'm not saying you should only use this, you should not use antidepressants, but not considering this, I think it's very important that you realize that you're doing a great disservice and you're not looking after the general interests of patients, because the simplest thing is to give the medicines and give them antidepressants and knock them out. Just a warning over here that it's slightly different in bipolar patients. So do not club bipolar patients along with the depression. Bipolar patients have these components, but very often I've been asked by the person that after, if you're not sure in bipolar, be careful. Bipolar patients are not the right kind of patients, but pure depression patients, yes. So I have covered all the 3 points that you wanted me to cover. Now my last one is here like this. I say that everybody should have the knowledge and you should consider. Do not jump at it. Do not say that this is great, fantastic, I'm going to get my T3 and soon I'm going to be well. So what you do is, if you're not happy, your symptoms are not gone away and your TSH is normal, you're taking the T4 or whatever, it's not happening for you. First ask your doctor that maybe the TSH target is wrong, because every time we say that 0.5 is the lower one, now they say no, 0.3, and those targets are changing day by day, and they're saying no, actually they could be a large people who were previously considered abnormal, but actually they're fairly normal. So that you should make sure that the target TSH is also correct. If you ask me, I'd like to keep everyone below 1. I'm not even looking at 2.5, but that's me. There are many others who may disagree. then you always do a lab test and check the metabolic, check the cortisol, check the other hormones, and ask about the compounded T3. Because here what happens is, unlike in the US where you have RMAT thyroid, you have many preparations available in the market.
Right.
In India, we don't have that, so you need to compound it. And even there are those thyroids that come from natural desiccated from pigs, and those which are not from pigs. And I prefer not to use anything that has pigs in it for multiple reasons. But my idea is to compound the thyroids which is not from any of these animal origins, and see that that's how we do it. But then it's a matter of choice. So you can get it compounded. There are many doctors like Dr. Preeti, and in your city or online, if you go, you will find doctors who do not do it on your own. And in any case, you will not be able to do, because a prescription will be required. Under the supervision of a doctor, you will definitely do it. Sometimes even other brands, even within the thyroxine, if you change it might work. So this is where I would end over here. Preeti, you can give the conclusion.
Thank you, Dr. Vivek, for such an insightful discussion. I know T3 was new and it had so much to say in between. And in fact, I enjoyed every word of what you said. If we have any questions later on, Dr. Vivek, I will send them to you and we will answer them. Thank you very much, everybody. And if you have any questions, do write to us and we will get back. Thank you.
Thank you.
Thank you. Bye-bye. Yeah, thanks. Bye-bye.